Ladies and gentlemen, good afternoon and welcome to this Facebook Live being broadcast via Gloucestershire Live and the Gloucestershire Hospital's Facebook pages. This is the fifth of a series of programmes that we've been running, I think really quite successfully, to actually ask you, the public, how you want to see your hospitals in Gloucestershire developing. I'm Ian Mean. I'm nothing to do with the hospital. I'm a former editor of the newspapers here and in Bristol, and I'm a director of Business West. So I ask the questions basically as an independent voice in all this. Can I just remind you what we've been discussing so far over the past 5 weeks? First of all, we discussed gastroenterology in patient services, then acute medicine, trauma and orthopedics, general surgery, and today we're discussing image-guided interventional surgery. And before we start on that, I'd just like to introduce our guest today, headed up by Deborah Lee, the very busy Chief Executive in an amazing week for the National Health Service with the new vaccine. Ray Ramnarine, who's a consultant interventional radiologist, David Cooper, who's a consultant vascular and endovascular surgeon, and last but not least, Lucy Elliott, who's matron in cardiology and respiratory. Now, Ray, I have never heard of image-guided interventional surgery. What is it?
Yeah, you're not alone there. Image-guided surgery is a term that we use here locally, and it's to describe a group of procedures that we can do, and to get the kind of technical stuff out of the way. How we do it is we essentially use X-ray guidance, and it's relying on small and keyhole cuts to do procedures all over the body. The unique model that we're just talking about here today is the fact that there's lots of us in the trust from different specialties who essentially do the same thing, and the British Heart Foundation ran quite an interesting ad campaign about a year or so ago about cardiovascular disease, and actually all of us here treat cardiovascular disease. It so happens that Mr. Cooper treats that in the legs, and Lucy and her group treat that in the heart, and I kind of straddle both groups. So we're here together to talk about, a collaboration, bringing together of our three specialties to effectively treat our patients who have a disease process in arteries, in veins, in organs that we can access using image guidance, and hence image-guided surgery.
Now, can you tell me how you hope, what your hopes are for the vision of this surgery in Gloucestershire?
So I think we've been very lucky over the last few years in that we have very strong groups of specialists in each of our specialties, and we've been collaborating over the last few years about how can we improve the care that we offer our patients. And what we were seeing is that some of our patients were disappearing off to other trusts, and actually, we thought there's a lot of the procedures and a lot of the patients that we can treat here locally if we can kind of be more collaborative in the way we do that. So the image-guided surgery hub is about kind of bringing together our three specialties to say, what can we do differently? What can we expand? How can we treat our patients better? And certainly in terms of the work we're doing, we're trying to expand. For me, certainly we can do more around cancer care. There are lots of procedures I can do in terms of offering cancer care. There's lots of work I do in collaboration with Mr. Cooper in treating people who have vascular disease. So it's about expanding that service and saying to our patients, look, you don't have to go elsewhere to do that. We can do that locally.
And where would that service be based?
The image-guided surgery model is primarily going to be based around the greatest need. So a lot of what we do is acute care, absolutely. So that would be in the site that has our big ED department, our A&E department, where a lot of our unwell patients coming into. That perhaps would be Gloucester. But also, we're a group of specialists who we'll see elective patients, we'll see day case patients, and we are doing a lot of planned care as well, and that will encompass a lot of complex work, in Cheltenham as well, treating patients on a more planned basis.
Yeah. So am I correct in thinking that you would, under your vision, you'd have the right people in the right places, so to speak?
Yeah.
One of the challenges that certainly interventional radiology and all of us face is the fact that, certainly as an interventional radiologist, there aren't many of us in the country, and nationally we're short about 400 consultants. And putting consultants aside, we rely quite heavily on our allied colleagues, radiographers, nurses, care assistants, and there is a huge shortage nationally. And we all use, we're a team, and we all use these individuals together to help our patients, and trying to get those people together is just much more efficient. Otherwise we've got to double up on people. So we're lucky in that we've got a group of core people. We need to expand on that. We need to roll with the kind of the progress we've made. And with things like the University of Gloucestershire now having a radiographics program, that's really exciting stuff, and that we can really push the homegrown radiographic stuff. And for me, I'm really excited about that, because one of the things that holds me back is the fact that my radiographic colleagues are pulled pillar to post, and there's not enough of them. And we are losing, and frankly, we are losing them to larger trusts around us. So here's the opportunity to kind of say, no, you know what? Let's build an exciting new model. Let's take this forward. Let's keep them here.
Right, that's great. And an important member of your teams, we've got one of those nursing specialists here. That's Lucy Elliott. Now, Lucy is a matron in cardiology and respiratory. She's going to talk about the interventional side of that. Lucy, what do you do, and how can these changes you're proposing help patients?
So we use interventional guided surgery for patients who've had heart attacks that come into our hospital. It's the quickest way to treat them and to unblock the arteries in the heart, which is shown to, the quicker we do it, the better the outcomes for the patients, and is definitely the course of treatment we'd like to offer. Currently our service offers that Monday to Friday 9 to 5, and if you're fortunate to have a heart attack outside of those hours, then you will be taken straight down to Bristol. And I think by having this I just heard, we will be able to expand our service that we deliver and offer it up to 24/7. That's the aspiration for the service. So we are treating everybody in our county, and that's what I'm looking forward to being able to do.
Yeah. So that would be at Gloucestershire Royal.
Sorry, can you say that again?
That would be at Gloucestershire Royal Hospital.
Under these proposals?
Yes.
Under the proposal, yeah. Okay. Thanks very much, Lucy. Now going to turn to David Cooper, consultant vascular and endovascular surgeon. David, can I ask you perhaps a very silly question to you? What is vascular surgery?
So vascular surgery is basically an umbrella term which defines a specialty which looks after arteries, veins, and to a lesser degree lymphatics. So there's a number of different disease processes which can affect them. Aneurysms when they swell, atherosclerosis when they block, and in the same region, vein disease such as deep venous thrombosis and varicose veins. And we provide a wide variety of interventions, some conservative, some associated with health and optimizing health for patients, but also managing things with big open surgery and also minimally invasive surgery guided by imaging to try and treat them effectively with minimizing the hospital stay and the physiological insult to patients. And where I suppose vascular surgery is different from many other surgical specialties such as urology and cardiothoracic surgery is that we work very much in tandem with interventional radiology colleagues and indeed on our own to provide a lot of these image-guided techniques. So placing stents, performing angioplasties and other similar interventions. And that's one of the reasons, obviously, why we work so well together with both cardiology and interventional radiology, because we're doing similar things for similar disease processes, and it makes sense to have all that expertise and technology in the same place.
Yeah, and your vision then is like Ray, to have, as I say, the right people in the right place.
Yeah, so centralisation to some degree and reconfiguration has been common within health specialties over many years, and the driving force for that's a concept called volume outcome. So if you do a large amount of a certain thing, you usually do it better. You get very slick, efficient. You see enough of it to recognise the sort of rare occurrences and what have you. But obviously, if you put a group of vascular surgeons together in a building on the A40 on our own, the outcomes will be appalling. And we need the infrastructure and the expertise of related health specialists, diabetologists, care of the elderly, interventional radiology, cardiology, emergency departments, etc., to be able to deliver these outcomes to the best of our ability. And there's good evidence to support that. And the other thing to say is that a significant majority of what we do actually is on patients who enter our service in an unplanned fashion. So they come in an unplanned way through our emergency department. And we have a lot of surrogate markers in vascular surgery, as we do in cardiology, that your outcome is not only dependent upon how much of it you do, but how rapidly you provide that service. Yeah. So providing an efficient service close to the front door and providing that service in familiar circumstances with familiar technology and familiar staff with familiar pathways is all about getting all set up to the best of our ability to provide the best outcomes.
Now, that front door service, as you say, is all about better service for patients eventually, isn't it?
Of course, yeah. And we want to remove any differentiation depending of what kind of care you receive, depending upon who you are, where you live, what's wrong with you, and when you present, and how you present. So whether you come in through clinic, whether you come in through emergency departments, what's wrong with you, and whether you present at 12 o'clock midday or 12 o'clock midnight. And that's obviously quite a labor intensive and quite an expensive thing to deliver. And so you have to concentrate that kind of service and that technology in the same place to be able to provide it as efficiently, effectively as possible, delivering outstanding outcomes.
Yeah. Now, during COVID, you've had a model working like this, haven't you?
To some degree. So vascular services were reconfigured in the county several years ago, and so we have developed quite a robust infrastructure over that period of time. And the thing that changed during COVID was that with the difficulties managing COVID positive and COVID negative patients and different pathways, and also the stresses and strains upon delivering emergency care, meant that in order for our patients to have access to safe levels of junior doctor support, access to emergency theatres, and access to other things such as radiology support day and night, we've had to reconfigure the services a little bit more in line with the Fit for the Future structure. But what we've learned from this is actually infrastructure is a crucial part of this, and what the Fit for the Future process gives us the opportunity to do, which is the first time I think we've really done this in a very joined up, ambitious and strategic way, is to develop a service which can use location, infrastructure and co-location of specialties to do this in the best way possible for our patients. Oh, I've lost sound.
Yeah, you've lost sound, Ian. So I'm going to come in here. And just to note, one of the things that I wanted to just tease out, because we've talked about the fact that the majority of patients who need this life and limb saving care will be around the Gloucestershire Royal under these proposals. But what's especially innovative about what this team has come up with is recognising that there are, albeit a small number, but there are some patients who can also benefit significantly from this. We'll still have urology patients, we'll have cancer patients being cared for at Cheltenham, and the model that the teams come up with allows them to support those teams, those surgeons, those oncologists to also deliver care, as we've said, in a planned way, largely, rather than as an emergency. And I think that's making us feel pretty unique. You heard some of the pride in the way that people were talking about this. You know, we are absolutely pushing the boundaries here with something that is at the forefront. And finally, Ian, you've guided me through 5 of these conversations where those 8 miles between Cheltenham and Gloucester have been described at times in a way that feels like 800 miles. But of course, what we haven't talked about are the patients who continue to go to Bristol or Birmingham or Oxford or even London to receive care that this team in the future will be able to deliver in Gloucestershire. So that's many, many hundreds of miles, many, many hundreds of patients each year having to leave the county for something that under these proposals would be delivered locally. So it's absolutely fantastic. It's groundbreaking. To quote you from previous weeks, it's a no-brainer. And we still can't hear you, Ian. We've lost sound. So what I'll do is just lead us through the next.
Hold on. I'm okay.
We've got you back.
David, have we got you back?
Me?
Yes, we did, David.
Good. Look, David, can I ask you about equipment?
Yep.
This equipment you work with, everyone works with, is very expensive, isn't it?
Sure.
And it doesn't sort of make a lot of sense to duplicate that, does it?
No. So we have got lots of bits of this equipment already, and it's a bit like running a vehicle, running a car. It's used day in, day out, and it chalks up many miles. So part of this process we've got is something we need to do anyway. We need to maintain, and we need to replace, and we need to service all of this equipment. What we've currently got is we've got equipment which is developed through evolution over the years, made by a number of different manufacturers with a number of different protocols and processes to use it on a number of different sites. And what we hope to do with this process is actually get a set of high quality equipment made by the same manufacturer, so everybody knows how to use it. It all works in similar ways, and it's maintained as part of a managed equipment program, meaning that it's kept up to date, it's kept high quality, it's kept working, it's backed up, and it's just more robust, so we can have it available to us to use for these patients, regardless of the time of the day and night.
Thanks, David. Now, Deborah, over the last 5 weeks, we've talked lots about these big areas of your operation: acute medicine, general surgery, IGIS today, trauma and orthopedics, gastroenterology. Have you really got the capacity to deliver all this? It sounds great, and you're a great talker, but can you deliver it?
I'm a great talker, but I'm an even better deliverer. That's what I need to say at this point, don't I? So this is complex stuff, as you're rightly pointing out, and this isn't something that's going to happen overnight. So what colleagues here are describing and what we've heard in previous weeks, it requires us to develop our estate. It requires us to purchase and build new equipment, and really importantly, as we've heard today, requires us to develop a workforce that we don't have right now. So this is a vision that we've implemented over a number of years. But one of the benefits of actually getting this strategy agreed is that when, as does happen quite regularly, the money is announced from government, we've got a case, we've got a clinical strategy, we're first in the queue to put that forward. If our response is, oh, hang on, we'll go away and think about this for a few months, can we come back to you? Then we're at the back of the queue. So, and again, attracting the best and retaining the best means we need to have this vision, and we need to have this vision agreed so people know what they're signing up to, and people stay because they can see we're serious about these things. So it is going to take time, but yeah, I'm very confident that we can deliver this. Money will always be a challenge, but in this case, we've got a plan to develop that. We've heard a lot about efficiency. So this is and I know it's not a popular word, but this is a more efficient way to work. And what does efficiency mean? Well, for patients, efficiency means you wait less time for your operation. You may spend less time in hospital. So although it might sound like a bit of a bureaucratic word, efficiency, actually for patients, it typically translates into a better experience and something that they would sign up to all day long.
Yeah. Have you got a feel of the time frame for delivering all these new changes?
We do, and it's over a period of time. So you'll be aware that we were really fortunate in successfully bidding for £39.5 million of capital from government a couple of years ago. It's taken a little while, as it always does in public services, to get that business case up and approved. We're at the final stages of that approval, and we'll hopefully be putting a spade in the ground towards the end of next year. So we're talking about a 2022-2023 time horizon for some of these changes. But there are other things that are about the ways of working that we can put in place if we get the support, through the public consultation and from our boards as early as next April. Yeah.
Deborah, before I talk to you about COVID, I just want a quick ring round the rest of the team there. Lucy, very briefly, how do you see these changes being operated?
Lucy? To me, sorry.
Yeah.
Yeah. How do I see them being operated?
This is a vision, but it seems to be very realistic. It's going to happen.
Well, for me personally, as I manage the nursing workforce, I see the benefits being operating, bringing together teams of nursing that will work together and provide a bit more resilience within our nursing workforce. I think everyone's aware of the nursing shortages we're facing at the moment, and by bringing the training together of radiology nurses and cardiology nurses into one service line will help support that.
Okay, thanks. Ray, what about yourself? Is this all realistic, these changes?
Absolutely. I cannot tell you how realistic this is. We have a really strong group of cross-specialty professionals who are wholly dedicated to improving patient care. Blood, sweat, and tears. And we, yeah, absolutely. And it's just everything is this is not pie in the sky stuff. This is realistic, and this is about addressing inequality, and it's about access for all our patients, irrespective. And I'm really passionate, and I hope that comes across. I'm really passionate about that.
Great, it certainly does. David, blood, sweat, and tears, realistic.
Yeah, so this is an example of actually developing our estates to optimize our healthcare. And the other thing I always say, it's an example of there may be an upfront cost, but there'll be a hidden efficiency and saving an outcome behind it, as opposed to the other way around, where you have an upfront saving and a hidden cost. So yeah, this is deliverable, and this is exciting, and let's get it done as soon as possible.
Yeah.
Good. You sound like Brexit. You need to be in the cabinet. Deborah, this has been a momentous week, hasn't it, for the health service? Someone I heard yesterday said this, the vaccine was probably one of the greatest innovations ever in this country. And when we look at it, and we look at the background of Edward Jenner in this county, with the heritage that has given us, this has been momentous, hasn't it? And also momentous for your trust.
Absolutely. I think I saw a tweet yesterday about walking on the shoulders of giants. As you say, Edward Jenner, the discoverer of vaccines, was a Gloucestershire scientist. We've got many parts of our hospitals, haven't we, named after him. And the smallpox vaccine, which changed the landscape in terms of disease, it was attributed to him. So there is something very special about this for Gloucestershire. But I think it's much bigger than that, isn't it? This is, as you know, this is a global innovation. This is a game changer for us globally, not just in the UK. I am, however, really proud that the UK went first. I'm really proud that Gloucestershire was chosen as one of just 50 hospital sites to deliver the vaccine in the first week. One of my colleagues, Kerry Holden, was interviewed this morning as the first colleague to receive the vaccine in Gloucestershire. So yeah, it's a truly incredible moment.
Yeah.
We've got you. We can still hear you. What I will cover, because I can see we've just had a question from somebody coming in from the public, is is just to know what happens next. So we've heard that the priority groups are those that are working in care homes and in the NHS, and particularly people who are over 80 and resident in care homes. So that's very much been our focus this week, is to make sure that as many staff working in care homes get the vaccine. I've been in the centre this morning, and the queue was predominantly staff working in care homes. We've also been vaccinating people in our hospital beds who are over 80, so giving them the opportunity to have their vaccine. But the big rollout will start in the weeks to come, when 10 centres across Gloucestershire will be established. It's a don't call us, we'll call you moment. So you'll be invited through the priority group. So again, starting with those over 80, people will be invited to attend one of our locations and receive their vaccine, and to come back, as you probably know, 21 days later to receive their booster. So, phenomenal logistical operation, but one in which my team have absolutely risen to the challenge. I do have to name check my chief nurse, Steve Hams, because I sit opposite Steve in my office, so I've seen a bit more of those blood, sweat and tears over the last week. So to be there myself on the first day to welcome the first member of staff to have their vaccine was, such a special moment. Really,
Right.
really proud and privileged.
Big question, Deborah. Is the vaccine safe?
And it's a question, it's a really important question, isn't it? It's a question that I entirely respect many people are asking. This was different to usual approaches. So what happens is we have lots of trials. At the end of those trials, data is presented to the regulatory authorities, and they look at a whole raft of facts and figures and safety data. Because we were keen to break this cycle of global transmission, this pandemic, this time around the regulators engaged from day one. So it may seem as though we've only been at this for a couple of weeks, but in fact the regulators have been working with all of the pharmaceutical companies, including Pfizer and BioNTech, to understand this over a long period of time. So in my view is that it is safe. I will be having the vaccine myself, as will many of my eminent colleagues who know much more about science. But as always, we will be exercising caution. There are some groups of the population for whom it won't be advocated. So if you are unwell, for example, at the current time with a fever, we wouldn't give you the flu vaccine or the COVID vaccine. If you've got a history of reactions to drugs or vaccines, and again, we won't be advocating it. So a really careful and cautious approach. But yes, I do believe the vaccine, if carefully administered to the right patients, is safe.
Good. And can you give us an update of where the hospital is in terms of COVID patients?
Yeah, and it's disappointingly busy. So I've sat here for 2 weeks now saying I really hope that we might be turning the corner. So let me start with the positive. We can see from the data in relation to what's going on in the community that the lockdown in Gloucestershire has had a really considerable impact. So thank you to everybody that suffered for some more weeks to enable us to try to reduce the transmission rate in Gloucestershire. And I know that was hard for lots of people, but we have seen that now. We've seen a significant reduction in the numbers of new cases appearing in the community. It takes about 10 days for that to then translate into a reduction in people presenting to hospital. We've talked here before about the nature of the incubation period and how you get these phases. And once hospital admissions have peaked, we then have about another 7 days when our critical care admissions peak, because those that have been admitted often don't become poorly till they're 7 or 10 days into their illness. So we are at the peak, 166 patients in our beds, 12 of those in critical care. The first wave, we had 148 in our beds at the peak, but we did have 33 in critical care. So again, that picture of people being caught sooner, treated well, using some of the not new drugs, but drugs with new indications, steroids, dexamethasone, you've heard me talk about, getting those treatments to patients really soon means that people are getting the treatment they need without deteriorating. The mortality rate, so the number of lives lost, considerably less as a percentage in this wave than it was in the last wave. It's too many, which is why, the hands, face and space message, can't be, overstated. This vaccine, wonderful though it is, and it is the start of a journey back to, new lives. It'll be many months before we've got a level of I know it's an unpopular term, but until we've got herd immunity in our communities where we can say you don't need to wear that mask and distance. So for many months to come, and particularly, I've said it before, but I am anxious about the festive period. So I am going to repeat my counsel from previous weeks there, is that we are anxious in the health service, because we don't just want to be about COVID this time around. We want to keep doing cancer operating, we want to keep doing hips and knees and the things that my colleagues on this call do. We want to see patients in outpatients still. We've not only got backlogs, but we know that people have been exposed, as Ray talked about, to inequalities. We've got communities who are poorlier as a result of COVID than they were before. So one way of keeping all of that going is to work really hard not to have that third spike in January that some think could be a consequence of the festive period. So my counsel is, does it need to be 5 days? Could it just be Christmas Day or Boxing Day? Is it 3 families? Might it just be 2? Perhaps maybe have a walk rather than sit around a table playing a board game. And if you've got older people or vulnerable people at home with you, I'd be wearing a mask and I'd be keeping my distance. And when you're singing your carols, rather than happy birthday, washing your hands for 2 minutes as frequently as you can. So, this is not over yet. It's a momentous week and it is the light at the end of the tunnel, but we're not out of the woods.
Absolutely. No, big message. Lastly, this over the last 5-6 weeks, I found this really interesting. And I think, as an editor here for the last 20 years here in Bristol, I think this has given certainly me a better understanding of how the health service here operates in terms of your hospitals. How do you see this consultation? Because this has broken new ground, isn't it?
Yeah.
You're, in my view, quite a different chief executive. I've worked quite a lot over the years here. Some have talked, some have not talked. You talk a lot, but you also do a lot. So is this working, do you think? Is this communication about what you want to achieve working for you?
So I'm going to take that as a compliment, just in case there's any doubt in anybody's minds. I'm different in a really good way. Thank you for that, Ian. But yeah, I am a big communicator, because I think a lot of what fuels people is anxiety and fear about the unknown, or half-truths. Let's name it. There's a lot of anxiety about what is the real agenda for Cheltenham Hospital, what is going to happen. And so this has been my chance to come and say to the public, we want 2 centres of excellence. We want 2 vibrant hospitals in the county until somebody gives us that shiny new one in 30 or 40 years' time. But this is about seeing them as an opportunity, not as a problem. Seeing that they bring opportunities for us to do things really well through this centres of excellence model. And I hope that we've communicated that in a way that we haven't managed to do before. Actually, it's funny, isn't it, the silver linings of COVID, because I've done this for 20 years and I've stood in village halls and parish halls with one person and their dog. Actually, what we've achieved through the virtual engagement, more than 50,000 engagements on Facebook Live each week. How would we ever have got that if we'd have been engaging and communicating in the older fashioned ways? I mean, importantly, not least because we had that 4-week lockdown, we are doing some face-to-face events because that's what some people, that's all that they can access. But we've had far more engagement. We've had 429 formal, really considered responses to the consultation, and we've got till the 17th of December. So I'm confident we'll have more. And what I'm really pleased is that half of those have come from the public and half of those have come from my colleagues, both inside the trust and in other organisations. So I don't remember a scale of engagement and an interest in health services anywhere that I've worked. And I hope what we've done is bust some myths, enthuse people with our vision. And yes, there's some compromises for some people who may not have access to local services, but what those people have told me is if I have to travel in either direction on the A40 to get better outcomes and better care, it's a no-brainer.
It is a no-brainer. And as I say, having edited newspapers here for nearly 20 years, I've taken a couple of big things out of this. And I was a reporter and someone said, Ian, I need you to write a story about this consultation. I'd probably take away 2 things. One is that you do need the right people in the right place at the right time. And I think the guests today, Lucy, David and Ray, exemplify that. And also 8 miles is not a lot of distance, is it? Especially in an ambulance or in a car. And to me, it's a personal view. This is all a bit of a no-brainer. We need to have a health service that people are comfortable with, they're satisfied with. And certainly this is a momentous week for the NHS. And I'd just like to end by saying we congratulate all of you and thank you, Lucy, Ray, Dave and Deborah. And please, the survey is open. As Deborah says, it ends the consultation on the 17th. Please actually take the time to fill in those forms and certainly enjoy the benefits that the health service and our hospitals give you. They are so important. Thank you.
And finally, Ian, just one thing from me, because we have rightly focused on the things we're consulting on, but it would be remiss of me not to note that's a small amount of what we do. So I think it's really important for people both in the east of the county and the west to know when it comes to having images, having outpatient appointments, having day surgery, much of what we do we'll continue to do in the same place. So this is about making the best use of the scarcest resources for the most expert things we do. And I just want to stress that, because I would hate anyone to think that the 8 miles comment is saying that we're pinging. So, this is the minority of things that we do, not the majority of what we do. But thank you so much for your kind words.
Absolutely. And thank you very much for your expertise.
Thank you.